Yes, I hear you.
Thank you. Hi, everyone. It's a pleasure to be here today. My name is Thomas Zaba. I am the IPC nutrition specialist with the IPC Global Support Unit. And again, a pleasure to connect with you. Thank you.
Thanks, Thomas. Faith, please.
I hope you can hear me. Faith Nzioka. I'm working with the GNC as a cluster coordinator in the rapid response team, and I'm happy to support today's webinar. Thank you. Back to you, Antony.
Thank you so much. Okay, for the rest of us, since we are many, like 50 plus people in the webinar, would you please write your name, your position, the country where you are joining from at the chat box? Okay, so this webinar will be about an hour and a half up to 2 hours. We will, as usual, will be more of a communicating two-way. We try to keep it as conversational as possible and as interactive as possible. There is no really dedicated Q&A session, but we will be taking questions in between sessions. So feel free to raise your hands or write at the chat box. Faith will be looking at those questions, raise hands, and we will address your question and comments accordingly. Okay, so with that, I think we can start. So today's webinar, as shared in the message, the invitation message is about using alternative data sources, proxy indicators, and expert judgment. As you all know, data availability is a common challenge in nutrition sector need analysis, whether the analysis is for a flash appeal, for HNO, or any ad hoc need analysis exercise at the country level. We all often encounter this challenge of data scarcity. So in today's session, the main objectives are first to share the current available recommended need assessment in the analysis practices in data poor context, where there is data availability challenge, there is data scarcity, and we share the experience from IPC AMN, GNC scenario 3 analysis. For those of you who are familiar with the Global Nutrition Cluster Need Analysis method guidelines, you know what scenario 3 is, but if not, don't worry, we will explain later. And we will be sharing also experience from the GF 2.0, which was launched last year. It has been used since 2023 for specifically for the 2024 HNO exercise. So we will be sharing what we know so far with regard to using alternative data sources, expert judgment, and proxy indicators. The main purpose, in addition to sharing this information and knowledge, is to provide you some technical guidelines so that you explore various data sources and organize these data sources in preparation for the 2025 humanitarian needs overview process. And I should mention here that this is not a deep dive on how to do analysis using proxy indicators and alternative data sources. A more detailed step-by-step guidelines will be provided on this topic sometime in August in our HNO webinar. This is just to share the information, a general guidance about how we do proxy alternative, how do we explore alternative data sources, use proxy indicators for analysis, and how we do expert judgment for need analysis. But the step-by-step guideline in the HNO process will be discussed sometime in August. Okay, so what are we covering today? First, we will look at common challenges in data availability. I hope this will set the scene for the rest of the session. This will be followed by some various scenarios of data scarcity. Not every country, not every context is the same. Recognizing that, it would be good for us to look at different scenarios of data availability and how we go about in each context. And this will be followed by alternative discussion on alternative data sources. That session specifically will be facilitated by Thomas from IPC AMN. In that session, he will also discuss about data reliability assessment, how we assess the reliability of a source of data. And this will be followed by proxy indicator. How do we select proxy indicator? What we mean by a proxy indicator itself. Then selecting proxy indicator is not sufficient for need analysis. Every proxy indicator should have some kind of threshold in order for us to use this for severity analysis in a specific context. So we will be discussing about the severity threshold recalibration. Someone, excuse me, someone should be muted.
Demande audience.
Who is the okay, thank you. Please mute your mic so that we avoid interruption in between the session. Okay. So we will discuss about recalibration of the severity threshold of proxy indicators. And finally, we'll speak about expert judgment in need analysis. So before we start, go to the next session, I would like to run this quick poll and see what do you think about the data scarcity problem in your respective countries. So let me just okay. Can you see the poll? Faze, Thomas, can you confirm
yes,
if
we can see. Yes.
Yeah.
Okay, great. So the question is, which one of the following data availability related challenges have you encountered in your most recent HNO or other needs analysis exercise? I mean, you could choose more than one answer. Just to help us know which one of these scenarios reflects your context. It could be one, or it could be a combination of. So are we seeing the result? So far, only 27 responses. Okay, we wait a bit. 30 responses out of 67 participants so far. It seems no more response. So perhaps just to save time, I will stop the poll. So overall, we see that this data availability challenges that has to do with coverage and timeliness of the data and robustness of the methodology have been experienced by the countries who are represented here. So this shows this is really a common problem, and I have no doubt about it because I do support our team, the GNC team, supports several countries, at least 30 plus countries every year. They do HNO or they do flash appeal. So we know that this data availability is a common problem, a common challenge. And what you see on the screen reflects almost, in most cases, the reality that we are experiencing when it comes to the need analysis challenges. Here, I would like to share the most recent finding from the GF 2.0, which is the methodology we use for HNO analysis. And in their most recent lesson learned review, which was conducted earlier this year, it identified some challenges when it comes to using outcome indicators in need analysis in the GF, both for nutrition and other clusters within the OCHA coordinated mechanism. So according to this lesson learned finding, the analysis using reference outcome indicators such as wasting rate, mortality was not adequately undertaken, and better communication on the importance of these steps and solution to address data scarcity and more practical advice on how to use the results are required urgently. So this is both the problem as well as the recommendation how to address the data scarcity challenge. So as you can see, among the outcome indicators used for HNO analysis, wasting rate, GAM, mortality are among the other indicators, but the use of these indicators was difficult because availability of data on these indicators was difficult. And there are some specific mention of challenges identified that has to do with data unavailability, lack of identified proxy indicators, and of course, lack of clarity on how to use those proxy indicators for the need analysis using the GF 2.0. So all the challenges that have been highlighted earlier, they reflect what you are experiencing and also the GF 2.0 need lesson learned review also acknowledges that. And for those of you who are not familiar with the GF 2.0, this is a methodology we use for the HNO. And GNC participated as a member of the technical working group at the global level. I have been part of this discussion, and almost every cluster acknowledges that data availability is a challenge, and there is a need to explore the use of proxy indicators to improve the need analysis process. So in 2025, the GF Global Technical Working Group with a global expert group recommends country coordination mechanisms to explore the use of proxy indicators. And while doing so, they shouldn't also compromise the quality of the analysis. Use of proxy indicators is recommended, but it shouldn't be in the expense of compromising the quality of analysis. And secondly, they requested every cluster to provide more concrete guidelines and communication on proxy indicators and expert judgment. And these guidelines and recommendations will be reflected on the HPC 2025 guideline. As most of you, I hope you know that by the end of May every year or early June, OCHA Global releases the global step-by-step guideline for the upcoming year HPC process. We do hope that some guidance on the use of proxy indicators and also guidance on the communication on using proxy indicators and expert judgment will be included in that orientation package or in the HPC 2025 step-by-step guideline document. So overall, as you can see, there is a consensus on the problem, on the challenge, and there is also a general recommendation how to address it. And also recently, as you all know, we collected the country assessment plan for 2024. We collected, I think, from about 21 countries. That information also showed that the coverage of assessments using robust methodology like smart surveys is low in most of the countries. We did this review as usual with IPCA amenity, and we came to know that most countries didn't plan to conduct smart surveys, and they were looking at other alternative sources, but those choice of alternative sources were not consistent. So we thought it would be good to provide some uniform guidelines so that they, whenever they opt to use alternative data sources, they should do so in a more systematic way rather than in a more random and ad hoc way. So we thought this webinar will help you to understand how to do that. So again, let me just run a quick poll on just to validate our overall assessment of your country assessment plan, whether or not what the information we collected so far reflects what you think about the assessment plan for 2024. So just a quick poll. There we go. Okay. Can you see
Yes.
the
yes,
poll?
see it.
Thank you, Faith.
Yeah.
So the question is, what is expected coverage of the Smart Nutrition Survey and or other nutrition household survey in your country in 2024? This is about what percentage of the country will be covered by a methodologically robust nutrition specific or nutrition related assessment in your country. So far 24 response. Let's wait for a couple of more responses. Okay, it's not moving. So I think it shows us some picture of the status of the coverage of planned smart surveys and other household surveys. So as you can see, about almost 70% of countries this year, their smart survey or other household survey, nutrition household surveys can only cover less than 50% of the country or the areas of interest. So this shows that significant part of the country, which is almost more than 50% or so, will not have data, most recent data from household surveys or from a representative survey, which shows the nutritional status and other contributing factors, including mortality. So this is quite a significant problem, and we cannot simply ignore this challenge. I think we need to provide you some kind of guidelines as to how you go about this data scarcity, data availability problem. Okay, so in the next sessions, what we will do is we will be looking at different scenarios. First, we start with contexts where gamma or global acute malnutrition is greater than 5, which is the case where we conduct IPC acute malnutrition analysis. And we have also contexts where global acute malnutrition from available data shows that GAM is less than 5. Please get muted. I see someone speaking. And thirdly, we have also contexts where we do not have data on even GAM, and there is no information. So how do we go about exploring proxy indicators, alternative data sources, and expert judgment in these 3 scenarios? But before that, I would like to take a minute or two by asking you a question about how do you address the data availability challenge in 2024? We saw from the poll that most of you are not able to conduct standard surveys in at least 50% of the countries, or more than 50% of part of your country will not have data, most recent data from household survey. How are you going to address this challenge? Or how have you addressed this challenge in the past? So let us take maybe a minute or two to hear from you. And I would be happy also to take maybe a couple of hands just to hear what you think about or what your experience with regard to exploring alternative data sources has been in the past year. So feel free to write at the chat box how you went about the data scarcity challenge in your country in the last year, HNO, in the most recent, or how you think about addressing this challenge even in 2024. What are the things that you have in mind to address this challenge? So please write as a chat box, and I would be happy also to see a couple of hands from countries to raise your hands and share your experience. Any volunteer? We have many countries represented. I hope you had some experience related to overcoming this challenge of data availability. Excellent. Welcome, Kutab. Go ahead. Kutab. Can you hear me? Kutab, we cannot hear you. Faiz, can you hear Kutab?
No,
I'm
we
not
can.
hearing.
Can you
Not
hear me
yet.
now? Oh. Can you hear me now? Kun?
We hear you loud and clear. Go ahead.
Okay, many thanks. Thank you very much. Hi, everyone. This is Kutab. I'm a specialist for the nutrition cluster here in Afghanistan. I will share my experience from last year here in Afghanistan, and then I can also share my prior experience in South Sudan. So I hope these are the two kind of experience which I want to share. So last year in 2023, we were not able to conduct any smart survey, and uh, mm, uh, and we unfortunately when we were calculating our case load, so we were not we did not have the luxury to have the up-to-date information on prevalence. So what we did, we discussed in our IAM technical working group. We also discuss among the team, and we think that this would be better if we can think about other factors like AWD, IPC data, and also the proxy indicators from screening. So we actually think about, so how we did, we try our level best to reflect like the changes in population from IPC, like for example last year and previous year, and we try our level best to adjust our prevalence. Then we also use the AWD, the difference between like previous last year and then year before previous year. So we actually adjust our prevalence on that and the difference. So and then because we know that luckily we also had screening data, proxy indicator from a screening information. So we were looking at the difference between in the screening data and the proxy indicator from the previous year and last year. So in the year where we see that the situation is deteriorating, we took we try our level best to take the upper confidence interval from our last assessment data which we adjust. So these kind of things we done last year. So this is one experience we did. I will if we have time I can also give another example, Anthony, if we have time, from South Sudan, which we did in the time of um, uh, COVID-19. So that was another example. If I have time, then I can do that. But that one actually, one example was from Afghanistan. Over to you, Anthony.
Thank you so much, Kutab. Yeah, as to my understanding, you highlighted a couple of points. Thank you for sharing those experiences. One, you looked at the past GAM data and you make some adjustment by considering the change in the contextual situation, which in my opinion, is more of expert judgment plus, of course, with using quantitative data. And also you explore alternative data source. You do not have most recent data from GAM, but you looked at morbidity data, which is a health sector data, which is an immediate determinant factor for acute malnutrition. Yeah, so that shows, already there is some experience with regard to using alternative data sources and proxy indicators. So thanks for sharing that experience. Let me take more. If as we have
We
who
have two
was
more.
okay, Abdul Basit.
Quresh?
Okay,
Yes.
okay, go ahead. Go ahead.
Okay. Yeah. This is Dr. Qureshi from W2 Sudan. Just in Sudan, the latest representative data that is available in Sudan is the S3M 2018-19. And since then, we have not done like a nationwide any survey. So each year, because after that COVID came, there was political instability and there was dry spell and then food insecurity level, finally conflict came. So how we were getting each year's like data, how we were doing like updating our figures for HNO, for example. So that was the a team of like led by nutrition cluster and UN agencies and other NGO partners together with Ministry of Health. There was a team of, we call it strategic advisory group, where the experts are there. So the available data, which was based on the prevalence from the that S3M survey that was conducted. So we were just keep updating that one. For example, after that, there was any representative small scale surveys conducted, for example, smart surveys in certain localities. All those figures were keep replacing with the new figures. But for the where we didn't have the new surveys conducted, so based on the expert judgment and based on the other driving factors that, for example, the IPC, where the IPC level is very high, for example, IPC 4, 3, or some states has been affected by conflict, some localities have been affected by conflict, some of the, there are more IDPs. So based on that expert judgment, we had applied certain percentages on the figures or the numbers of the which was coming from the previous prevalence. So for example, in some areas we applied 30%, 15%, and 10% like that. So with that, we could get like a new figures for the HNO and for our HRP. Thank you. Over.
Thank you so much, Abdul Basit. Again, you highlighted the fact that there's some kind of adjustment or in the use of indicators, which is proxy. Use of proxy indicator was explored in your case. I think also I go back to Kutab's mention of the experience in Afghanistan. He mentioned about expert judgment. In your case also, Abdul Basir, you mentioned that. One key point I would like to underscore is whether or not such expert judgment or use of proxy indicator was based on consensus or not, whether there was a consultation of the partners, key experts within the sector or not. So you don't have to respond to the question, but keep in mind that whenever we make this kind of adjustments, it's a must that there is a consensus. But anyway, I will not go to the details of that. We will discuss that later on. But so far, what I'm hearing is this is not something new, and GNC or IPCMN is not there. We're not trying to reinvent the wheel. We are just consolidating all different experiences from countries, and so that you have a consistent application of this approach in addressing data availability challenges. I see Mabasa's hand, and after that phase, you go quickly through the comments on the chat box. So Mabasa, very quickly, please.
Good day, everyone. Thank you very much for this chance. In Myanmar, for the past 2 iterations of the HNO, HNRP, or HNRP, if you like, we've had to depend on using proxy indicators to estimate our needs. And we are very grateful for the support that we've received from the Global Nutrition Cluster when we are getting ourselves into these estimation activities. Mainly because the context is such that there aren't any recent and representative surveys or assessments. The Day Smart Survey, DHS, and things like that. The last DHS that was done in Myanmar was in 2015, 2016, and I think given what has happened over the years, that kind of data is quite obsolete. So we've had to make use of these proxy indicators be they from the multi-sector needs assessment, health indicators, food security indicators, and so forth, and throw them into the mix to be able to estimate the needs in Myanmar. It's quite an experience, it's quite a challenge, and I think I would put forward a request that if it were possible, given all the lessons that have been learned across the globe, there's probably a need for some kind of a protocol, I don't know if I could call it that way, that probably just guides those that are in those difficult circumstances of data scarcity to be able to support their estimations with some kind of guidance that's kind of rooted. Thank you very much, and over to you.
Thank you, Mabasa. And yes, yeah, Myanmar is a good example. Actually, I included Myanmar in the later slides as the example where we used other sector data, as Mabasa mentioned, to do the need analysis, because simply outcome data on nutritional status and mortality was inexistent for the last couple of years, and even from other alternatives sources, we couldn't find anything of significant to do analysis. So we have to resort to use of other sector indicators. So that's really a good example. Just to save time, Faith, shall I hand over to you to take us through the comments on the chat box?
Yes, and I think, yeah, majority is just what has been said by our colleagues. But yeah, just to add on some of the issues coming from the chat, we have from Jafed Khan about, pushing partners to do more smart surveys, use of the past surveys, and extrapolating data from other areas. Of course, the use of MWAC, screenings, use of data from food security vulnerability assessments, and there's a mention of adopting a Smart Plus. I think that is a new ways of doing a smart service nowadays with the reduced cost, but still it is at limited coverage. We have, let me see if there's something else coming out. There's from Mozambique, from Edna, about use of early warning systems to maximize the use of routine data and better define where and when to conduct more in-depth assessments. And also, yeah, trying to use a NUFAC initiative, which is also implemented in the country, that is Mozambique. In Venezuela, we have, yeah, they're saying they have huge challenge of data availability, no smart surveys, but I think they are making use of analysis of secondary data, which is collected by partners, and also specific workshops on prioritized regions to validate information collected and analyzed, and analyze with the reality of the regions, and official information is not available in the country. Yeah, so I think, yeah, most of the things have already been mentioned, but there's a question, maybe if you could maybe address it before you go to the next session from Edina. About sharing the step-by-step guideline that you've mentioned that you'll be sharing during the HNO webinar later in August. So they're saying in Southern Africa, as you already know, because of the El Nino conditions, they are already doing response plans and doing a nutrition analysis, and they'd like to make use of these yeah, guidelines. So if that could be shared earlier, yeah, it could be appreciated. Thanks.
Thank you, Faiz. Thank you, colleagues, for sharing your experience. It simply validates the points I was making earlier, and also the live poll we did. Data scarcity is a problem. You already are exploring various alternative. Colleagues, please, can you mute yourself? Colleagues, please mute yourself. So it validates the points I was making earlier about the fact that data scarcity is a challenge, and countries are exploring various ways of addressing that challenge. And as you can see, there are some creative ways of going about it, but we are not sure whether this practice is consistent and guided by some sort of protocol. And Mabasa earlier mentioned about having some kind of protocol, some kind of guideline to help you go about exploring these alternative data sources and using proxy indicators, of course, all with expert judgment and consensus. So what we are trying to do today is to give you some best practices as much as possible, but this will not be the end of it. We try to consolidate all these experiences, available guideline, and as I said, during August HNO webinar, you will have more guideline. And as we speak, also JNC is participating in the GF technical working group, which is assigned to actually work on this specific task. Specifically, the GNC and food security clusters are tasked to come up with alternative indicators, proxy indicators, alternative data sources, expert judgment guideline. We are working with OCHA also to give you some additional, more detailed and clear guideline. So with that, let me just rush through the next slide. So different countries, as we hear from colleagues, they have different experience. Their context is also different. Some countries, the GAM rate is greater than 5, which is a case where IPCM and exercise need to be done. And for those of you who are familiar with the GNC need analysis guideline, we call this context GNC scenario 2, meaning GAM is greater than 5, and our analysis depends on using outcome indicators to classify the severity. By outcome here, I'm referring to GAM and mortality. So we use those indicators to classify severity of the situation and, of course, the magnitude of the needs. We have also another scenario where the GAM is less than 5, and it's usually assumed that this is an acceptable level of GAM, but we do know that in low GAM contexts, there is still a problem of malnutrition, and this situation also cannot stay permanent. Especially in case of changes in contextual situation, like in conflict, there could be deterioration, but the GAM may not be the immediate indicator of that deterioration. There are some determinant factors, indicators that we need to look at to do a proper need analysis in those contexts. So we call this scenario 3 need analysis. Is already included in our guideline, in our tool. I hope some of you have used it. We also interacted with you in using this scenario 3. And we have also some countries, especially new emergencies, where there is no GAM data, or if at all it is available, is very old. And the only option we have is using other sector data, which is the contributing factors, excluding some nutrition sensitive indicators. So we have also this kind of scenarios. Now, we start with the most common one, where GAM is greater than 5, but we have data scarcity challenge. So with that, I will hand over to Thomas to take us through what alternative data sources should be explored in contexts where we know that the GAM at some point, based on past data, is the GAM is greater than 5. So what do we do in those kind of contexts? But the other scenarios, I will come back and take you through some of the best practices we know so far. So with that, I hand over to Thomas. Thomas, the floor is yours.
Thank you, Anthony.
I will move the slides. Please tell me to move.
Okay. Once again, good morning, good afternoon, wherever you are. So we will talk about the alternative data sources for nutrition need analysis when there is scarce evidence on global acute malnutrition, as Anthony pointed out. Anthony, you can move to the next slide, please. So the main objective of this session is basically, as I said before, to know what the alternative options are in those contexts where you have limited resources or inaccessibility due to different reasons, conflict, or maybe there was a cyclone and then you cannot access part of the area, and you still need to provide a needs overview for that particular area. A disclaimer, however, here is that whatever is going to be shared here with you and also learning from you, it's not a prescription per se to ignore the need of having or going always first for the standard and reliable methodologies representative like the smart surveys or any other population-based surveys that allows you to tell stories in a more robust way. You will understand in the next sessions that what we are going to share with you comes with a lot of limitations, and it's always important to take that into consideration before the decisions are taken. Next slide, please. Okay, this is in the context of IPC, and maybe you know what IPC is overall, not the acute malnutrition per se, which we will touch base in the next slides. But we thought it is important to bring this context to you, especially on the structure of the IPC, which is a multi-partner initiative. So the GSU doesn't own the IPC per se. We just coordinate it. The IPC is owned by all global partners who are part of the IPC partners. And the main objective is to improve food security, nutrition analysis and decision making. And that's the reason why we are here, because that's where within the HPC humanitarian program, you do your needs analysis and to inform your needs and later the responses. So we have 3 scales here, just for your information. We have the acute food insecurity scale that looks into the acute food insecurity per se, and then the acute malnutrition and the chronic food insecurity. So we will touch base on the alternative data sources to be able to conduct an IPC acute malnutrition when you don't have the standard like smart surveys conducted in your area. Next slide, please.
Thomas, I cannot hear you. Is it? Can you hear us?
I can hear you.
We can also hear
okay,
Thomas. Maybe the issue on your side. Anthony, he says we'll go to the next slide.
Okay, sorry, maybe it's from my side. Okay, go ahead. If you don't mind, can you be a little bit louder? I don't know if it's from my side or from yours, but be a little bit louder. Thank you.
Okay, I will do my best. So what is the IPC acute malnutrition? What is the reason why we do an IPC acute malnutrition? And linking this with the reason why we are here, the HNO, the needs overview overall. You have to know that IPC works hand in hand with the HNO. And the primary objective why we do the IPC acute malnutrition is to inform the humanitarian needs overview. So if you don't know, the IPC acute malnutrition, we say that it's a set of tools and procedures that we use to classify a given area based on the prevalence of acute malnutrition, the global acute malnutrition, right? So later you will see what are the sources of that prevalence of acute malnutrition to then be able to classify that area. And then we identify, or the IPC identifies the key drivers. Why is acute malnutrition at that particular level? And obviously to provide actionable information, something that you can use to act upon. So we seek to answer 5 sessional questions, and then you can see here how those questions, they feed into the humanitarian needs overview. Just to second the fact that I said the IPC works hand in hand with the HNO. So the first question we try, or the IPC seeks to answer, is how severe is the situation? And where, so the worst affected areas. And this tool helps you set your prioritization. Then you have question number 3, when is the situation severe, where, and then you have why is the situation at this phase, at this particular time, in this particular space. This information helps you build a narrative in your HNO. And then obviously you have how many, the magnitude of your problem transformed into number of children, as well as pregnant and lactating women. And this goes to the magnitude. But obviously you can also use these in other contexts, because at the end of the day, it's a situation analysis. That's what IPC is. So you can use it in those contexts where you don't have an HNO per se, but you have acute malnutrition prevalence greater than 5%. Next slide, please. Okay, all right. I think you have moved to the next slide. I wanted to ask the colleagues on the call, how many of you already have a plan to conduct an IPC acute malnutrition in this year, 2024? And that will serve as a basis, to also link with what we want to say in the next slides. If you could type in the chat box if you have any plans to do an IPC, and if you don't, what is preventing you from planning and doing an IPC? Okay, I see here that.
So do you see any comments?
Yeah, I see some. One comment from
okay, colleagues,
Pakistan.
just say yes if you are doing IPCMN this year. If you don't, no. Very quick. Those of you who are doing yes. Mozambique, yes. Chad, yes. Only 2 countries. We have more of them, but
yeah.
Okay.
Okay, we can go to the next slide. There's another yes, but we don't know the country. Venezuela, no. Okay, on this slide here, you see 2 different tables. The first one on the left side, show you the number of countries where we are currently implementing an IPC acute malnutrition. And you see we have 19 countries. I'm just realizing that Djibouti is missing here. Sorry, Deka. There are 20, including Djibouti. And then we also have the countries doing IPC, acute food insecurity. And you see that there is a considerable difference in numbers. And one of the major reasons why you have less, so we have less number of countries doing IPC, is due to data scarcity. So again, this is a perfect timing to come to this event and then share with you the alternative solutions for having data to inform the IPC, and then obviously the HNO. Next slide, please. Okay, so the different options to collect nutrition data, and if you don't mind, if you can possibly type in the chat box what you think are the different, beyond the SMART, because we know very much that you are very acquainted with the SMART methodology, the different options beyond SMART. Do you know any of them? If you could type in chat box. Maybe the writing is taking longer. All right. So there are different sources. And here we provide a useful decision tree that helps you decide on what you should consider in case of when the first, second, third option is not available, for instance. So as you can see here, we have this SMART survey. So here we call it full SMART survey, the standard SMART survey, or any other representative surveys, population-based surveys at that particular area of your interest, which we know you know very much about this. So when this is not feasible for a variety of reasons, then you can think of doing the rapid SMART survey, which is also specific to some context. You usually a small geographical area with a very defined sample size. You usually go for 25 clusters and a minimum of 200 that particular area, and with a very limited, usually only limited to anthropometrics, because you want to do it in a very short period of time and to give you an overview of the situation in that particular area. So we understand that you probably know very much about these two options, but probably not very much about the other three options that they described below. And because of that, we want to spend a little bit more of time unpacking the three options here, and then see how, and then you can reflect how these could be applied in your context. We can move to the next slide, please. Okay, so let's start with what we call sentinel sites. Imagine you have a surveillance within your nutrition information system in your country. You probably have a surveillance mechanism. We know there are those health facility-based sentinel sites and also community-based sentinel sites. So for IPC purpose, we only consider the sentinel sites that are coming from the community at community level. And these sites, they are usually purposively selected based on a preset of criteria that you agree upon at your level. Maybe there are some areas that are more vulnerable within, let's say, a district, a county, a yard. There are some communities inside those different administrative structures that are more vulnerable to acute malnutrition compared to others. So you want to pay attention to those specific areas and keep monitoring the situation. So this is what we describe about sentinel sites. So they are community-based sentinel sites. We say here for IPC, to be able to use it, to meet the criteria for IPC, the prevalence will be calculated by taking the average of those different sites. And we say that there should be at least 5 sites per unit of analysis, per district, per county, per sub-county, etc. You should have, from those different communities that you believe acute malnutrition or the nutrition situation is more vulnerable than the rest of other areas, you should have at least 5 sites. And then at least 200 children with valid measurements in total, children 6 to 59 months. So if you have this criteria in terms of sampling, then we do a check, and then we proceed to check the quality of the data. So we check the quality of the data the same way how it's done for surveys, right? Running the plausibility check, and then looking at those different tests that tells you how the healthy of your data, whether it's good, excellent, or problematic. But also, if you have a repeated MUX screening from same areas, let's say, for instance, you are doing it for referral purposes, etc., but it's coming from the same area, from the same season, then this can be treated as sentinel site, and then you can use it also to in the IPC. But obviously you will have to also check the quality of it. So it depends on how the data from this screening are recorded to enable you to perform some minimum quality checks. Because as you will see in the next slides, in IPC, only an evidence that is being checked in terms of quality can be used in IPC. If there's no ways how you can check, then it cannot be used. If in your area you have part of communities are pastoralists, then the minimum number of 5 pastoralist areas is applied, but with a relatively smaller number of children that goes up to 100. A number of children 6 to 59 is acceptable. But in a normal agricultural communities or with other livelihoods that are more stable, etc., we would expect 200. Next slide, please. And please, if you have any questions, you can keep writing in chat box, and then we will be addressing. So that slide was about sentinel sites. Just to wrap up, those locations that you select based on a certain criteria to monitor the nutrition situation, those are sentinel sites. And as long as you have at least 5 communities, 5 sites, and in total 200 children, at least 200 children, if they are not pastoralist, and the quality of data is good or falls within range, then that can be used in the IPC acute malnutrition, and consequently to inform your humanitarian needs overview for that particular area. So if that is not possible, it's inexistent in your area, the next layer of possible source of data are screenings. So the screenings can be either exhaustive or targeted. Exhaustive when depending on the scope of your area, again, district, county, sub-county, depending on your case, we call it a screening if you plan to screen all children in that area, or at least 80% of children 6 to 59 months from that area. So to be able to use in IPC an evidence and acute malnutrition prevalence or prox prevalence coming from exhaustive screening, you should have at least 80% coverage of the planned population of children 6 to 59 months from that area of interest. And obviously, that prevalence or prox prevalence should come from the same season of that you plan to do the analysis of the same year. And this is usually possible for those countries who are still doing the child health days or child health weeks. Then adding another layer of maybe teams or integrating different other teams can be a possibility because you usually go everywhere in those campaigns, vaccination campaigns, polio campaigns, or any other health events. You plan to target all locations in that area. So that's how you can think of integrating. And then if you have at least 80% and it's from the same season, you can use it in the IPC acute malnutrition. Then we have the targeted screening, which is something similar to what we described, or I described it before on Sentinel sites, but the difference is that it's one-time screening. The targeted is different from the screening because, is from the Sentinel site because it's one-time screening. If you remember in the previous slide, I said if you do frequently screenings, even if targeted, then that can qualify as Sentinel site. But if it's a one-time screening, then we call it a targeted screening. And it's targeted because you have a particular interest, let's say, to a specific areas in your district county, and you target your screening to those specific areas. And the reasons why you target them can vary. You may have, for instance, a natural disaster that may have affected with great severity part of a district, and then you want to understand the impact of that disaster in that particular area, so that you could employ the targeted. You wouldn't go for exhaustive because you are not interested in the whole district, but only the areas that were affected by the natural disaster. Or it could be for any other reason. But as long as you are purposefully selecting, or you could also think, if you believe that the problem is homogeneously distributed, you don't know an entry point to say, okay, I'm going for these instead of those, you can think of doing a random selection of communities where you want to screen. So those areas that you see called sites can be randomly or purposely selected. So randomly, as I said, you don't know if there are areas of greater concern compared to others in the same region. So you employ a random selection of what we are going to say in the next point. But if you believe that there are some areas that are more vulnerable than others, then you go for a purposive selection. And I have given an example on how you can think of going purposively. After you have selected, if you go either randomly or purposively, so you have the sites already or communities already selected, you have a second stage, which is within community selection. So the within community selection can also be either random or exhaustive. You usually go for a random selection if the community is bigger enough that you cannot manage to finish within the time frame. And an exhaustive, when you have less than 200 children, estimated number of children, 200 from that community, then you are expected to do an exhaustive screening within that community. So please note that, imagine you have 3 communities. Let's say you have selected one community randomly, 3 communities randomly, either way, and you are already inside that community. The approach to selecting children can vary from one community to another, depending on the size of population size, I mean. So your entry point is, if you have more than 200 children estimated for that community, then you think of doing random selection of households, because children are found inside households. But if you have less than 200, then you go for an exhaustive screening. And again, the list that you should aim for is 80% of the planned number of children or expected number of children in that area. And you should have at least 3 sites per unit of analysis per area, which in this case can be districts, can be counties, can be depending on your context. For that particular area, you want to do your screening, you should have at least 3 sites. And from those 3 sites, you should have a total of at least 600 children. So here, if you have 3 sites, you aim for 200 in each site. But you can think of if your site, whatever you consider to be a site, community, villages, the more smaller the sites, then you would be expected to have more to be able to reach 600. But if your sites are bigger in terms of population density, then you would expect to have those at least 3, and then the likelihood of getting 600 in those 3 will be also high. So these are the differences between the exhaustive and the targeted screening. But they have one thing in common. If you have taken note, we were talking about this sampling in size of number of children in these 2 approaches. But one thing that they have in common is that 8 of them, we perform quality checks, because nothing is piped into the IPC acute malnutrition before it passes the quality checks. So in order to perform those checks, your screening should have at least these 4 variables. You should collect for every child you measure. You should collect the children's age. Preferably, it should be recorded in months. But if it's not possible, then you can estimate the children's age to categorize it if less than 2 years or greater than 2 years. But obviously excluding children under 6 months. So there's someone speaking. I don't know if it's addressing to me. You should, in addition, collect also the sex about the child, either boys or girls. And your MIWAC measurements should be in numbers. So we know most of times we are only concerned about knowing if the child is acutely malnourished and then enrolling it in a program. And going that way, we only care about colors. So if the child falls within green, we say it's okay. If the child falls within yellow, we say it's moderate acute malnutrition, in red, severe acute malnutrition. If you have your data in such a way, green, yellow, red, there's nothing that can be done to check the quality, and therefore it will not be used. So to allow for checks, you have to have the MIWAC measurements in numbers. It can be in centimeters, it can be in millimeters, but they must be in numbers. And one thing that we also observe in many data sets that we receive in different countries around the globe is that in this screenings, edema is always missing, so it's not checked. You should also check and record if the child has edema or not. So if you have these variables in such a way how I described, then your team, or when the data comes to us, will be able to perform checks and then decide whether data can be used or not. Next slide, please. All right. Another point also we want to advocate for, let me use this word, it's on the need, it's linked to the quality of data. It's on the need of training whoever is going to do the measurements, to train them to be ready for the job. And I usually like to use this example of, the professional footballers, whoever you like, Cristiano Ronaldo, Messi, Mbappe, whoever you like, how many others. They are the top on the globe in terms of football, but they don't go for a match before they go for an intensive training. So operators, even if they are going, for a targeted screening, they should be prepared for the job. We understand that most of times they are people who perform these screenings at health facility level, etc. But if you want to come up with a prevalence and you want to take measurement in numbers, etc., you have to make sure your team is ready for the job. And you do that by retraining them, refreshing them to perform well the job. Otherwise, it's going to be messy. And so as you collect your data, ensure that there is always a dedicated person doing the checks. So this is usually done in small surveys or those big surveys, but it's always neglected or usually neglected in these screenings, etc. But it's also a must, actually, because you don't want to use an evidence that you cannot rely in terms of quality, etc. for any decision making. Next slide, please. So just for your information, this is a glimpse of the table, with the parameters we use to check if your data falls within range or not, or outside the range. And for more details, you could refer to what's now called the Smart MIWAC Smart tool, which has a lot of details on how you should do, to ensure quality, and whenever you have a specific problem, and then how to fix it, etc., which is linked very much with what we said in the previous slides. Next slide, please. Okay. So before we proceed to this next session, let me very briefly wrap up. So if you don't have a standard SMART survey or any other representative survey following a different methodology, but population-based, etc., you can think of the rapid SMART survey. If you don't have that, or you cannot, actually not that you don't have, but you cannot, then you think of sentinel sites if they exist. If they are not available, then you go for screenings that can be subdivided in the exhaustive screening, and there are criteria in terms of some sampling and the minimum that you should go for exhaustive screenings, as well as for targeted screenings. And all these have something in common, is that the quality should be monitored throughout the process. And that starts with getting your team ready for the job, which is about the training. Now, there are some of those situations, which they are not very common, but they exist, where none of the previous scenarios can be applied due to one particular reason. You cannot access that community, that population, due to conflict, or you can probably access, but with very limited period of time that you are allowed to stay in that community. Or again, you had a cyclone and then roads are cut off, and then you cannot access that community as well. So the IPC came up with a very IPC-specific guidance on how you should think of collecting data from such scenarios to still provide information on how do a needs analysis for that population. So in IPC, in the IPC manual, we call a special protocols for areas with limited or no humanitarian access. So the reflection is here how to go about these areas given the challenges. Again, what you have to think is in these areas, you don't have time, you are not allowed probably to spend a lot of time and then do what you should do in the normal situation. And what we are going to say here only applies for those specific areas. So in these specific areas, they are usually applied or typically applied in very small geographical areas, right? Because you want to have a glimpse of how the situation looks like. With this guidance, you can collect data on nutrition, so the acute malnutrition. You can also collect on minimum data on access to food consumption, and also if mortality is of concern, you can also collect data on mortality. So these are the type of indicators that you should think of collecting. Next slide, please. So one thing that you have to consider is, especially for these this session now that they limited on humanitarian access areas. The conditions, they vary from area to area. So what we are going to say here, like how you can think of collecting data, it's not like a one size fits all to all locations, because it might work in Sudan, but not work in Mozambique, for instance. So what we usually do is if you don't find this fit in your situation, so we ask you to reach out to, through the GNC or through us directly, and then together we will study your situation and then find the best way to gather any evidence that can be used for the IPC under these special protocols. So usually the selection of households and children should be random as much as possible. But obviously, it depends on the situation. So what you have to think is it should be random as much as possible. You should have a team composed of experienced people on sampling and data collectors on nutrition, food security, and if mortality of concern is including mortality, so that they can maximize the time they will spend there to bring something that can be useful, although or despite the limitations in terms of the reliability of the evidence. So this team should do MUAC screening. If mortality is also of concern, they should collect mortality data and food security. So the ways how you can deploy this team depends. Maybe you don't have access to that area, maybe for a long period of time, but then there was, they've been given access to go and provide food distribution. And so you should also think of maximizing that opportunity to deploy 2 or 3 people to collect MUAC measurements, so any other thing in a coordinated manner, obviously, and then use that to give you a glimpse. And within the IPC, you are also allowed, and this is also communicated in a such way that puts that disclaimer to the reader that this evidence was collected with the bare minimum standards. Next slide, please. So, as I was saying, if you are you have a food distribution happening, you should think of having one person of the 2 or 3 collecting measurements or doing measurements at the food distribution point, and then someone collecting or doing the measurements away from the food distribution, because maybe there are people who are not at that spot and others are still, at the house, so within the household. So you should also try to have these 2 people collecting different locations. And if adult malnutrition is also of concern, then you should also think of collecting the adult malnutrition data, and that could also be useful to mirror the situation of the rest of the population. Next slide. So this is about mortality. Maybe I will not spend a lot of time on this. You have maybe also seen that I have been skipping some of the points that are related to food security and just sticking to the nutrition. So for mortality, there are also these different options here, which is using the health facility data if the system is still working, but also going to the key informant interviews or grade counting. It depends on the context, but these are, as I said, these guidance are not like one size fits all. It needs to be contextualized to each area to make sure that you collect something useful to that mirrors the situation on the ground. Next slide. Okay, on the, and Anthony, this comes along with the previous session, right? Or we should take a pause there. Can you come on this?
Thomas, sorry. I was saying I think it would be good if you could cover this very quickly. And
okay.
Yeah.
Okay,
Go ahead.
Noted.
Okay, should I move to the next slide?
Yeah, you should move it to the next slide, yes. So as I said, maybe in various occasions throughout my session, any evidence used in IPC, it goes through a rigorous check. And I also said, these alternative data sources, and they come with limitations compared to the standard ones. So we are not promoting the use of these and de-promoting the other, the standard, the gold standard. No. We are saying when you cannot, but you still need to provide a narrative on how the situation looks like, acknowledging the limitations. So in IPC, we check the reliability of any evidence by cross-tabulating what we call the soundness of method. So whether the methodology used to collect that evidence and also taking into consideration the indicator. So we know that the best way to collect these indicators on acute malnutrition is through, for instance, smart surveys. So a smart survey in this context for acute malnutrition would be considered as a good method, so something sound. And anything that falls outside a good sound method, we call it limited. So I'm highlighting here that all these approaches that I described before, that I said that you could think of employing them in areas where you have access, they fall under limited method, as you can see here highlighted in red. So you have the Sentinel sites, the description about Sentinel sites falls under limited soundness method. The description about MUAC screening, either exhaustive or targeted, they also fall under limited method. So they are limitations. They are limitations, and they are taken into account as such in the IPC. They get a lower reliability score, and they are communicated also in such a way that any reader will understand that this has a lower reliability. We also have the time relevance. So the reliability score is a function of soundness of method and time relevance. So for time relevance, we also have two subgroups, good time relevance and limited time relevance. So we say that it's a good time relevance, anything that comes from the same season of that you are interested in for your class, for your analysis. So let's say you want to do an IPC acute malnutrition for a lean season. So to have a good time relevance, your data should have been collected within that same lean season of that same year. If obviously, okay, the season sometimes cuts across 2 years, right? Let's say from the end of 2021 year to the beginning of next year. So they should fall within the same season. So as you can see here, when you have good soundness of method and then good time relevance, you get a reliability of R2. So this is translated in such a way that this is a good, it's a reliable. Anything else outside R2, it's called somewhat reliable. So you have R1 plus, which means your method is limited, but it's coming from the same season. So if the evidence comes from the same season, you see that it has a highest, reliability score compared to an evidence coming from a different season, even if it's coming from a good method. So if it comes from a good method, but away from the season of your interest, then the reliability score is low. But if it's coming from the same season, but from a limited method, your reliability score is a bit more preferred because it translates into the actual conditions as you speak, obviously with limitations of representativeness, etc. So, and then you have the X, which is something that is away from good and away from limited. This X is not used in IPC. We throw the data away or put aside, but we don't use it in the analysis. And for the special protocols, the session before, the slide before this one, we have also, or the IPC has also a clear way how to communicate that by putting on the map an icon that depicts limited access, meaning the evidence was collected with very bare minimum standards. Okay, next slide. I think this is
that would
back
be
to
the
you,
end.
Anthony. Yes. Thanks.
Thank you, Thomas. Really a very information-rich presentation, condensed with a lot of information. We will share this material with everyone, including the PowerPoint, as well as also there is an accompanying step-by-step decision-making tree. So thank you very much, Thomas. Since we remain with 15 minutes, I will go very quickly since we have covered the main session, and for the rest of the session, we will have opportunity to discuss during the HNO, but I just would like to take you to more of to the analysis aspect. What would the analysis will look like when we use proxy indicator and alternative data sources? Or in another words, can we do nutrition need analysis without having nutrition status data, or acute malnutrition is acceptable level, which we usually consider less than 5 as acceptable? I hope you would say yes, because as you remember, we moved away from this conception of emergency nutrition equivalent to, GAM greater than 5 or 5, wasting. We moved to more of a comprehensive outlook with regard to the analysis of nutrition needs. So we look at nutritional status, mortality, outcome level indicators like GAM. We also look at some intermediary indicators like underlying factors or immediate factors. And using those data sources, we have been doing need analysis. And in fact, there are specific examples. We used it at some point in all of Syria. We commonly use it in the LAC region. There are colleagues, I believe, in this webinar as well from that region. Earlier, also, Mabasa mentioned about Myanmar, where we basically used other sector data to do the need analysis. So this is a common question from colleagues during HNO. The common question is, can we do need analysis, a proper need analysis, a quality need analysis, nutrition need analysis without having a GAM data or wasting data? Yes. So no GAM shouldn't be a problem, or low GAM shouldn't be a problem. We can do that, but how we do that, I just want to highlight 2 points. In case where the GAM is greater than 5, obviously, we look for IPCMN analysis, if that is possible. If it is not possible, we can do also scenario 2 need analysis. By scenario 2, it means we look at the nutrition outcome indicators and other contributing factors to do the need analysis based on these indicators. For those of you who are familiar with our need analysis guideline and tools, you know what I'm talking about, scenario 2. But in case GAM is less than 5, or GAM or wasting data is not available, what options we have? We have what you call scenario 3, which is need analysis, nutrition need analysis in contexts where the GAM is less than 5, or in some cases, the GAM data is old or non-existent. So how do we go about the data source aspect of it? For these indicators, for most of these contributing factors, the data doesn't come from nutrition sector, as you know. It comes from the food security, the health, the WASH sector. And of course, there are some nutrition specific aspect of it. For example, IYCF, that data comes from nutrition specific assessments. But again, conducting a population level IYCF study or assessment is very difficult. The sample size required is very high. So you can imagine the difficulty of getting that data. So at the end of the day, we will be mostly relying on data sources from other sectors. How we collect those other sector data, we cannot provide any guidance, as you can imagine, because it is not within our mandate. It is with other sector mandates. However, what we can do is we rely on other sector data and use it for our analysis. This we have already been doing, and here you can see on the screen the GNC scenario 3 analysis. And I just play the screen record of what it looks like. So we have severity classification, but that is based on other indicator, other sector indicator, food security, WASH, and health, and so on. So let me just play it so that you see what it looks like. So we have the food security, we have the WASH, we have, I believe, the health indicators, many of them, a number of indicators. And we can do severity classification by just using those indicators. And also we can, in some cases, we may have nutrition specific data, for example, micronutrient, or we may have IYCF related data. We can also use that. So we have the calculation, the severity calculation tool. We will make some modification, but at the end of the day, the idea is if there is no GAM or the GAM level is low, you could use other sector data, and that can be used for need analysis. That's the point I would like to convey. So moving on, okay, now we use other sector data, or we use the nutrition sector specific data in case where the GAM is greater than 5. We have maybe IMN analysis, or we just have the proxy indicators or alternative data sources. So how does the need analysis process itself looks like in that kind of situation? As I said earlier, at the beginning of this webinar, we are not going to provide a step-by-step guide, but we will share in the next slide what the overall approach, the framework looks like. in terms of approach. Okay. We have three aspects to it. One, we need to make sure that we organize our alternative data sources, which is right now before the HNO exercise, which usually starts July, August. Now we have time at least to look into other alternative data sources, conducting assessments using alternative data sources that were mentioned earlier by Thomas. And also I mentioned about other sector data. So we can work on organizing those data sources. And you could use alternative data sources both for nutritional status and mortality. You could also look at contributing factors and collect data from secondary sources or from other sector sources. That's one aspect of it. The other is you need to think about alternative data source means, in another word, you will be by default using proxy indicators, but you cannot simply use proxy indicator as it is. It has to be meeting certain criteria, which I will quickly discuss in the next slide. And whenever you use a proxy indicator, that proxy indicator should have some severity threshold, because we do severity analysis. And the threshold that applicable in some countries should be similar to other countries. So even if you select a country-specific proxy indicator or a common proxy indicator, you need to do recalibration of the severity threshold for that indicator. Okay. Thirdly, all this has quantitative aspect, but it all depends on expert judgment. So we need to apply some form of consensus-based decision-making, which relies on two steps. One, we need to look at the data reliability, which Thomas already mentioned about it. Within GNC, we don't use it, but we have that guideline. I will share after this webinar. We need to do the reliability of the data source. And we have to also look at the convergence of evidence. We are not going to unpack this topic now, but making sure that the level of evidence outweighs the uncertainty. So we need to have some level of confidence on our assessment or our conclusion about the analysis. And then, of course, all this should be a consultative process, and it should be a consensus-based decision making. So there has to be consensus. Consensus, then that has to be documented very well. Okay, I move quickly since we remained with 5 minutes. So how do we decide, a proxy is a good proxy or acceptable level of proxy? We have two sources which can be cited as the good sources. We have the European Commission guideline, and we have also the USA guideline on using proxy indicators. So proxy indicator is meant to address data gap, the data availability gap, and it should be understood as an approximation to the standard indicator. It could also employ alternative data sources, and proxy indicator should be somehow linked to the standard indicator or outcome of interest by some one or more assumptions. We should assume that if we choose a particular proxy indicator, we should also explain how that is related to the main outcome of interest. And that assumption shouldn't be a complicated one. It should be a very straightforward one. That would tell us, the proxy is at least a right proxy indicator. And there are also few considerations for you. We will share this and we will discuss more during our need analysis webinar during the HNO. But these are some of the three aspects you need to look at when selecting proxy indicator. Usually it should be quantitative and it should meet the usual indicator criteria, which is SMART, measurable, acceptable, all those the SMART aspects. And also it should allow the assessment of the same contextual situation as the standard indicator. I think this is very straightforward. The last important thing, this requires expert judgment and consensus and consent of the stakeholders. So if you are doing the selection of proxy indicators, then you should make sure that you consult the partners, the experts in your respective countries. Moving to the next one. Okay, we selected a proxy indicator. And how do you make sure that the selected proxy indicator is aligned with the standard 5-scale severity threshold? So here we have a guideline from the GIAF, the intersectoral method for conducting HNO need analysis. So there are 5 levels of severity. And this is the general definition of those severity scales. Whether you use X indicator, Y indicator, GAM indicator, mortality, or WASH, or food security, regardless of the indicator or sector, it should meet these criteria. Meaning, if you say the threshold for that particular indicator is 5, then it should show some extreme situation in which people have little ability to meet their basic needs. So each one of these definitions should be used to classify our proxy indicator severity thresholds in a particular context. How this is done, I'm not going to in details. We will come to this during the HNO webinar. But for you, just to know that we need to use alternative data sources. With that comes a proxy indicator. The proxy indicator should undergo through a peer review process of selection. Once it is done, we need to have a threshold, and the threshold should be done based on alignment with this global standard. This step, we call it severity threshold recalibration. The GIAF guideline gives some guidance on how we contextualize indicator and recalibrate the severity threshold. Okay, moving on. Okay, all this decision or discussion relies on expert judgment. You know, we are not just inserting some numbers and generating some analysis. We should make sure that it is consulted. How is this done? I just would like to point 2 aspects. OCHA, or the intercluster lead, is preparing a guidance note for the upcoming year HNO, which describes the process of expert judgment and then consensus-based decision making. So that will specify what sort of process should be followed, what sort of behavior in decision making should be demonstrated in the need analysis exercise. So we will not go to the detail, but it will be shared as a draft document. You can make use of that. But in general, there are tips we know from our experience. What would be the best way to go about the consensus-based expert judgment-based decision making? We have one from IPC, but we are not going to cover it given we run out of time. But here are some of the tips. One, when you do need analysis or even during the assessment planning phase, making sure that you form a technical working group, or if you have already a nice technical working group, make sure that you use that group. And we highly encourage everyone to take the GNC training as well as the GIAF training, which is available on OCHA e-learning platform and GIAF platform itself. So I will be sharing this link so that everyone gets educated on how the whole process looks like. There is a less detailed, more introductory version of the training, and I hope that would help. And of course, we have the GNC e-learning that would give you some idea how to do this one. And we will be incorporating expert judgment and over the coming weeks or so. And I hope you will have access to that. And the other aspect is making sure that you have a peer review process in your NIS technical working group. And also, as usual, whatever decision you make sure that you get it recorded, minuted, and you have to have a documentation of the proceeding of the peer review exercise. And then, of course, today we want to cover the IPC consensus-based decision-making tool, but given the time, we will not be able to do that. So I think we covered as much as possible what we wanted to cover, but we could share the expert judgment part, which is more of analytical process. We will have opportunity during the HNO webinars in August. Just to wrap up, I'll jump to the last slide. So what we covered today, we talked about the data availability challenges. We looked at the various scenarios of data scarcity. We talked more in depth on the data, alternative data sources, especially in the contexts where we can conduct IPC-MN, where the GAM is greater than 5. And we looked at how we assess the data reliability. And we talked briefly about the proxy indicator selection, what we need to consider. And also we talked about severity threshold recalibration process and what reference we need to use. And then, of course, we couldn't go in detail about expert judgment, but I did mention some of the expected guideline on expert judgment, which should be out by the end of this month. So with that, I think we should conclude the webinar, but let me take maybe 30 seconds or a minute if anyone has any burning question, please post it at the chat box, or just one or two final thoughts or questions if you want to share. Faiz, do we have anything on the chat box?
Yeah, we had only 2 questions. The first one was on the screening data results, if they can be used given the poor data quality, and I think that was answered through the presentation. Unless Thomas, you want to add something, or Mabasa is okay? Or you still need some more clarification on the use of mark data?
Which is from, is it from Edna?
From Mabasa, yeah. How much of screening data results can you make use of given the poor data quality? That was the question. But
I don't know, maybe Thomas can answer it very quickly. I didn't get the question. Thomas, if you hear the question, can you address it quickly?
No, I didn't. I was typing here addressing Edna's question. If you could repeat, please. Oh, Koki said we'll catch up later. It depends.
Yeah, we could. I think we could respond bilaterally since we are like 5 minutes over the time. So, yeah, there was also a question by Ines about, will this approach be used in the HNO only or in other cases, other need analysis? The short answer is it can be used in any case, whether it's ad hoc need analysis, HNO, any need analysis you do for a specific region as a gap analysis, it can be used in any circumstance that requires need analysis. Okay. So I think with that, we should conclude this webinar. I really thank the IPC-MN team and also my colleague Faiz for supporting the facilitation of this webinar. And also colleagues, thank you very much as usual for your active participation. Obviously, this is packed with a lot of information. We do not imagine that you are able to grasp everything in this session. We will be sharing the materials, and I hope you will get opportunity to learn more about this subject by your own. And also let us know if you really want to have one-on-one briefing or discussion on this one, and we will be happy to do that as usual. And of course, as I mentioned, we will be making adjustment on our need analysis guideline and also our e-learning material. And also, in our HNO webinar, we will be discussing more step by step how we do apply these proxy indicators, alternative data sources, expert judgment in the HNO process itself. So with that, I think we should finish. Thank you so much. And I hope it was useful. And yeah, have a good day, wherever you are. And just for those of you who are in Francophone speaking countries, please remind anyone who is interested in your sector that there will be a French version of this webinar next week. So thank you so much.
Thank you so much, Antenna, Thomas, Chris,
Thank you.
and all for like appreciate it.
Thank you, Anton.
Thank you all.
Thank you.